Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are with Dennis Jarema. Dennis is a retired 18 Delta, a registered nurse, and he is part of the Prolonged Field Care Working Group. Dennis, welcome back to the program.
Hey, thank you very much, Aebhric. Appreciate the invite.
So tell us a bit about yourself and what's keeping you busy.
Well, lots of busy things. I guess how far back do you want to go?
We have 45 minutes.
We have 45
how far
minutes.
back would you like to go?
Man, oh man. If you, I guess at the beginning, not birth, but the beginning of the military stuff. I joined the Army 2002, right after I essentially signed up after September 11th, like the vast majority of other people. I went to the infantry, deployed to Afghanistan, and that's where I saw my first casualty. And that's where I made my decision that not only did I want to join Special Forces, but I wanted to become a medic on top of that. And so that kind of started me on that journey. Fast forward essentially 2 years, I had graduated. I got to my first team and then, of course, deployed again. And I started serving in that capacity as an Army medic, SF medic, for a couple more tours with 7th Group. And, we had some family stuff come up and active duty was no longer a real option. So I left active duty a bit sooner than what I was prepared for. And so I also signed up for the National Guard, SF unit, 20th Group. And I was kind of in search of a job. One of the people at the unit worked at the schoolhouse there and said, hey, we're looking for people. Why don't you put in your application? I did. And I got hired. And I was teaching anatomy and physiology, which was absolutely the opposite of what I wanted at the time, because I'm sure you remember, like that whole section of the course, you have to be very knowledgeable. It's very academic intensive. And at that point in time, I didn't feel that confident in myself, just knowing all the answers, right? But I needed a job, so I accepted, and I just hit the books like really hard. And I started teaching, then I started getting better at teaching, and that's how things kind of started taking off. Roughly around, 2012, 2013, Colonel Reesberg came to JSOM and started chatting with me one day. And because at that time, I had started kind of including more things, I guess, into the lecture. Not like just ramblings of things, but like trying to relate to the students, like you have to know this information because, at that, what was it, 2011, 12, 13, like the GWAT was still going on and would continue to go on for a while longer. I was trying to start reminding people, like, wars begin and wars end. When the military leaves, like, we stay behind, but they take all their toys. So these rapid evacs are going to go away, and it's going to go back to you taking care of people for a lot longer than what you thought. And I think Colonel Reesberg at least heard about that. And that's when he kind of talked to me about the Prolonged Field Care Working Group and invited me to a meeting. And that's where things kind of started taking off.
So, Dennis, I'm curious about the fact that you are a nurse. So how did that happen?
So how that happened, one, I actually needed some kind of degree. I didn't have one. I was thinking to myself, because the classic kind of pathway from Special Forces medic is to become a PA or become a doc. All those are are very good options. And but I got to thinking, like, why or what did I want out of that kind of career other than, you know, money and seeing patients and, you know, all the good things, right? And I really wanted to stay kind of on the austere side of things. And so I was just thinking, well, who has the most experience with patients long term? And that's the nurses, right? And so that's what kind of got me to go into that general direction. I had the idea of becoming like a CRNA, maybe, or maybe a nurse practitioner. I hadn't really decided yet. But the first step is always become a nurse. And so I did an online program through Excelsior. And so I was able to work and do school at the same time. And which with that particular online program, there's one weekend where you actually have to. That's like you're testing out your final test, right? And it is a ball buster. Um, it is enormous the amount of crap you have to do, and it has to be like you remember in like the trauma lanes, right? In the course, you'd have, you know, maybe a sheet and a half of like step one, step two, step three, step four. Like these are all the things you need to do in order to pass, right? And those were hard. Well, this test essentially had the same thing, except it was, you know, 7, 8 pages long, and it started from the time you knocked on the door until you finished your nursing note. And you know, there's a time crunch on it, and they give you different tasks that you're supposed to do, and individually they're not particularly hard, but you have to do them exactly how they want you to do it. And so, like washing your hands, I've done it the majority of my life. I know how to wash my hands, but let's see, the process starts. You knock on the door, you introduce yourself to the patient, you don't touch the patient anyway. You walk over to the sink, turn the water on, get your hands wet, get soap in your hands, wash. Do not turn the water off. You have to get the paper towel, dry your hands, and use the paper towel to turn the faucet off, right? So your hands are stay clean. Of the, let's say there was 10 people in my testing group, and you have to do this. You see 3 patients over a weekend, which is not many at all. But of the 10 people that came that weekend to test, I was the only one to pass. And the vast majority of people get kicked out. And like if you don't follow the list, as soon as you deviate, you're done. Like there's no letter grade. It's you got this far. Okay, you screwed something up. You're done. And I was the only person to pass. And everybody else, you know, worked in the hospitals, and they knew what they probably knew better than what I did. But what I had over them is I was used to following the steps, and so I was able to succeed. I just turned my brain off and just followed the steps, which you of course have to have memorized, and I succeeded. But yeah, that was the reason is I wanted more experience being able to take care of people for a longer period of time. Because, you know, even just before I started with the working group, I was already thinking like, you know, every war begins and ends with, you know, a very small amount of people in a great big area, and people are going to get hurt, and you're going to have to take care of them for a longer period of time. So that's what I wanted to kind of, that's the direction I wanted to go, is to be able to do that and have the skills to be able to do that, so I can at least teach others, if not do it myself.
I look back I started my EMT in 85, 86. Looking back, I would be so much better of what I'm doing now if I had started as a nurse in the mid 80s, become an
Mm-hmm.
RN, and then went through,
Mm-hmm.
went SF or went critical care paramedic and all the way up through academia. I would be a better medic if I had started off as a nurse.
Yeah, absolutely. And it's a completely different thought process. Like nurses, you can't diagnose anything, like absolutely nothing. And so, the nursing diagnosis kind of pathway essentially makes this giant loop around, what the actual diagnosis is, and just does this big runaround for that. But since I already had kind of experience in that as a medic, being able to figure out this is what's wrong with somebody, but just understanding all the nursing care aspects of how to take a person from A to B successfully and healthy, I think is incredibly valuable.
The Australians have sorted this problem. They have a combined paramedic nurse bachelor's degree. Well, I think we should have that in the States.
Yeah, and I think that's one of the areas that nursing care is pivotal to prolonged field care. But that's one of the areas that I think a lot of medics have a hard time with, is knowing when to transition their thought process, when to start nursing care. Like there's never been a nursing class that I've seen that actually answers that question. So everybody just stands around and watches the patient, but nobody's doing like padding, and they will once you point it out to them. They're like, "Oh crap," and then they start going. But just understanding when to even start is a big hurdle.
That was a discussion that Jamie Reesberg and I had during the podcast, why people were doing march, pause, and then doing march, pause, and then doing march, pause. They're never transitioning into hitman, prolonged field care, sheep vomit.
Mm-hmm.
So no one knows. And so, yeah, when do you start PFC? And I have, at the college, we've created our CABC system where as you finish your vital signs, you have no choice. You move into H, hitman.
Mm-hmm.
It's just an automatic transition.
Good.
How do we do that for these guys who are just, as you say, they're not starting nursing?
Yeah. And, that's, in some of the other podcasts I've talked to, like Kevin Worth, who's also a critical care nurse, that's one of the things we talked about is like, well, when do you start as being also one of the austere critical care type units. And it's essentially, once you've done all the dangerous things, just immediately roll into it. Because I think when you do an algorithm, okay, however it is, March, then nursing care, there's going to be patients that fall out of that, where it might be a long time before you actually get out of March, or as you're doing nursing care, then something else happens to the patient. They start to decompensate, or they start to wake up, or they start to start to succumb. How do you be able to flow back and forth seamlessly between these two, I would say, roles, because just medicine has divided everybody's careers like that. One person's responsible for this, other person's responsible for that.
Right.
But when you're by yourself, you have to be all of the things, right? So how do you flow back and forth seamlessly? And one, I think, is just understanding the importance of it. It's one thing to say it's important, but if you don't practice any of it, then is it really that important?
And not a lot of people practice the nursing care when they go through TCCC.
No. Why would you? Right? We're only going to be there for 20 minutes. So turning the patient it's not going to be a problem. You never, in the TCCC, you never have to deal with infection, really. So everything is dirty. Nobody's wearing gloves. The patient's covered in mud. And it's not a real big deal because I've just done the things to save this guy's life. You don't realize that you also have done things that have now exposed him to, a higher likelihood of infection that might kill him in a couple weeks, just because you didn't clean it off.
is there scope for the H in March to include head injury, hypothermia, and Hitman? So they automatically go through H head-to-toe exam, eye infection, T-tubes. It's like, would that flow?
I mean, of course it flows. I mean, you wrote it down. But mentally, will it flow? Because they're essentially two. You're trying to mush two scopes of practice into one, which is what's needed. But understand, you really have to understand the why those things are important. Like I tell the students, I found in myself, the more experience I've gotten in prolonged care, the more efficient my marches become. And people are kind of, I think, confused, and that's because I've seen the long-term effects. So I don't make those stupid decisions early. I I don't, if the patient doesn't need a chest tube early, I just don't do it. I don't do it because he's got a hole in his chest. I do it because the patient needs it. My assessments have gotten better. I've gotten better at understanding what's going to happen, 30 minutes, an hour, 6 hours, 9 hours, 12 hours, 24, 48. Since I have a better understanding of what's happening, I have a better understanding of what the patient needs now versus, in an hour, 6 hours, etc. Does that make any sense?
It does. Yeah.
Like just turning the patient, putting the patient in prone, elevating the patient's head. Like if I already have, very limited amount of oxygen, I'm going to start those techniques early. So hopefully I don't have to use my oxygen at all, or I can at least be more efficient with it. And so I have that kind of understanding of, hey, I can use these simple things early and hopefully benefit more later.
Do you think PFC needs a CPG like Reesberg did for PCC to give people a document to follow that guideline?
I mean, I think the PCC guidelines, like, they work. They work. I think the soft providers or the people that have a higher skill level, they should understand that they can go farther. Like, just because now we're, the clock has swung by enough hours that we are now in a prolonged casualty care or prolonged field care situation, that they have more capabilities and they can do that. So I think that the PCC guidelines suffice, and it does what it's intended to, is to make it official. But like any algorithm, like, there's going to be patients that fall outside of that and need something else, or need you to deviate from the plan slightly. And I think while those are all well and good, and administratively very important, what the actual importance is teaching guys why we're doing it this way, and building those models of how they think and how they react. That's where the actual art of medicine happens.
It's getting them to think like an ICU nurse.
Yeah, but being able to respond like a ER doc, or, well, hopefully.
Easy. Yeah. Simple to do, right?
It is simple. I mean, I know that docs go to school for, like, I don't know, a long freaking time, but we can cram it into 1 year of training. I think when people set up training, they have to, just from the outset, actually think, what is it I want? What do I want them to do? And then build your training around that. If you want them to start including nursing care, well, then you have to teach them about it and then demonstrate doing it and why you did it. So I think that might be another thing I need to do, is I want to record myself and some others. Hopefully I can't do this by myself, but doing an actual prolonged field care lane, so that guys can see, hopefully, this is at least what right looks like. This is how, when bad things happen, how to respond appropriately.
No one's done that. It's only been written.
I know, it's scary. And when I think about it, I get nervous too. Like, crap, I'm going to destroy my reputation. But
Well, if you think
that's
of
okay.
nurses, there are tons and
That's
tons of
okay.
YouTube videos of nurses showing how it's done.
Yeah,
There's nothing of a SF medic showing how to do prolonged field care.
right.
So tell us a bit more. How did all this begin? I know that, 2013 at Soma, we was having a first conversation, but how did all of this begin? Was it all Jamie, or is it yourself and Paul Ose, or how did the prolonged field care working group start?
So that was at SOMSA, 2013. It had really nothing to do with me at all. It was all like Sean Keenan, who's the current president of SOMA, Jamie Riesberg, who's now retired, Paul Lose, also retired, and just having a meeting, kind of like a sensing session with other medics. And mostly it was about Africa because as other groups kind of just took over, Afghanistan took over Iraq, 10th group was kind of out of the loop a little bit. And so they filled in for third group going to Africa. And being fresh eyes in a new place, like they started seeing like a lot of problems for things that they were not used to at all, and that people get hurt randomly, but the evac times were ridiculously long, and the evacuation plans didn't really match the realities on the ground. Definitely not plans that they had from their trip to Afghanistan or Europe or things like that. So they had a big problem on their hands in that they weren't really prepared for dealing with that. In all of our training for GWAT, everything was, T-TRIC, ABCDE, just rapid treatment, rapid evac, and get back to the fight. And that's what was happening. So that's what we were trained, and that's what everybody's experience was on. And now, when you're talking about, you know, 12 hours, 24 hours, 96 hours of having to hold on to people, like you didn't have that kind of experience, you didn't have that kind of mindset of what do you do after T-TRIC, essentially. And so, people were looking for kind of the answers. Well, somebody has to fill the void, and that's where the prolonged field care working group kind of started, was at SOMSA there.
I remember that, 2014 was the first time I joined that conversation, and there was a big push for Africa. But looking back on it, there isn't a huge, or there hasn't been a huge deployment to Africa, and that whole push of prolonged field care was needed, even though we didn't deploy as heavily into Africa as we thought we would, because now we're using it in other places in Eastern Europe. But
Mm-hmm.
what was so the big push was Africa. What was happening then that made us think that Africa was going to be the next big hit?
Well, I mean, like most people know, I mean, you have superpowers all influencing different things. And so, the U.S. has to have a presence in this area as well, right? Um, just for our own national interests. So that's why we're kind of there, and we're, training local police, you're training military, just so that they can keep stability in their country or increase their stability in their country. And so that's what we were doing there. But the infrastructure was not really there, right? It's definitely not like in, Western Europe. Absolutely not at all like it was in Afghanistan or Iraq, and just the robustness of the medical system. And so that was kind of forcing people into very uncomfortable situations. It might not even be, um, GSWs or anything like that, just a sandstorm blowing over a tent. That story, that just crumbled people. And he had a broken pelvis and internal bleeding, and like I don't know how to put a tourniquet on a liver, right? So how do we handle this situation? How do we keep our guys alive long enough so that we can get the evac, so that we can get this guy to a next level of care?
we're going back to what we were doing in the 90s. So I was in first group in the 90s, and with a lot of deployments in the Pacific Rim, and there wasn't a 10-minute evac. And we're going and doing FID missions and JSETs in places that the only exfil we had would be commercial airlines, and but there was no talk about PFC. We were talking about evac, but there wasn't any thought process, curriculum, or a push for treating this casualty or with advanced concepts other than it wasn't even March. It was just do ABC and do ABC again and then ABC, and that was it. And thankfully, because of what you guys are doing, the Prolonged Field Care Working Group, we're going back to that same type of concept within the Special Forces battalions of going and doing foreign internal defense missions or JSETs or something without that 10-minute magic golden evac time. So we're kind of relearning what we were trying to do before. Look all the way back into Vietnam with the Hueys evacing as soon as they could. It wasn't 10 minutes, but so you have created, you and the Prolonged Field Care Working Group have created a curriculum, have a language that we just didn't have in the 90s.
Yeah, I mean, you think back then. I mean, how much just looking at hospital medicine, how much has changed since the 90s till now? You know,
tons,
and I mean, enormous amounts. Well, how do you bring that level of care to the field in a realistic way? And I think the working group has been able to kind of be that translator and maybe the Rosetta Stone between, intensive emergency care, intensive care type stuff, but in a field aspect, with the gear that we have and influencing the gear that we have, influencing the techniques, the procedures, just the thought process of how do you actually do this job effectively. People want to do a good job just inherently, but if you don't train them, if you don't even talk about it, then it's not going to happen. And then when something does happen where they need that, but they don't have the training, people succumb. The mortality, morbidity alone. But I think the reason why it didn't happen earlier is we're talking about small numbers, and so there wasn't a lot of emphasis put onto it.
There wasn't a language. There wasn't even a concept.
Yeah.
So when you were discussing this with Jamie and Dr. Keenan and Paulos and the rest of the group within SOMA, was there any discussion with the British SAS and the PFC that they'd come up with roughly 5 years before that? So like 07, 08, they created the Hitman mnemonic. And I learned about that when I was teaching the battles course there with the MOD in the UK, and they were implementing that. Was there communication between what you were doing and the people at the SAS in Hereford?
Not with myself, no, but both Sean Keenan and Jamie Reesberg, they had been to Europe, so they've seen what other forces have available. But being American, we like to take what other people do and rename it, and now it's American. So yes, it definitely influenced, and especially if you look at some of those early documents, you'll see Hitman, you'll see Sheep Vomit, and things like that. But I think what we're trying to do with the working group is essentially take the best from anybody and everybody, and see if we can streamline this into, a technique. I don't know if that makes sense.
Yeah, well, it's a technique that needs to be universal and accepted, so everyone has the same language.
Right. Because, all too often we're working together. And so if we're using different acronyms, different tools, different thought processes, like there's going to be miscommunication, and that's when the patients start to suffer.
Do you see a move away from Hitman and Sheep Vomit and embracing Was it the ravine mnemonic that was the original concept of the working group? What is the future of the mnemonic of the prolonged field care?
I mean, I think it's always going to evolve. Like March, they're talking about revamping the March acronym, uh, moving moving circulation above respirations, managing the chest. So to me, like mnemonics are helpful, but they definitely don't define anything that I do. Um, so I think that just like anything, all these mnemonics have to evolve with current practice and what's best for the patient.
Yeah, and hopefully get some research, evidence base,
Hmm.
some projects that will back up that with science.
Right. That's the big problem is with research. How do you do research about prolonged field care? The numbers are so small, the people are so scattered. How do you gather the data? How do you even begin? To set up an experiment.
So we can infer quite a bit from normal medicine, but you're right. There should be a bit more emphasis on research focusing primarily on PFC. And there's people who've published PhDs focusing on prolonged field care. And there's good feasibility studies. I think a lot of the published research on prolonged field care is a feasibility study, which is fantastic. But the numbers of actual hands-on study as we're doing prolonged care in a live fire exercise, it's there's not much out there, is there?
No, no, there isn't. For I think there's a variety of reasons. We're not going to send researchers out into the battlefield to document what's going on. It's hard enough to get guys to fill out their T-Tri-C cards to even begin collecting data. Um, so I guess what I would like to see is more people with that kind of experience having more influence on research that is meant to help, the austere type of environment. I don't know if that makes sense, but it seems like a lot of the studies that are done, it's, well, in the ER, this is what happens. Well, that's not at all like the environment that we're working in. I can't just infer all of that information and use it, in my environment. So being able to, we still need that somebody that can translate that. And lately, I've been doing, at least I've done two so far, podcasts with Alex Merkel,
Hmm.
one of the other members at SOMA. And we've started doing some podcasts on different research papers, pointing out the good, the bad about it, and can you actually use this paper in practice in an austere type location?
Yep, that is a challenge. The science that's working in an ICU in Duke University, is that really applicable for the 18 Delta or 68 whiskey who's in sub-Saharan Africa with just their ruck?
Yeah, and some of it is, and some of it absolutely is. But what part?
Mm.
Um, and I think if there was more communication between the research side, the researchers, and people with operational experience, you'd be able to get a much better study done. I helped a company that was working on a TBI type monitor, and like they didn't have a concept of this is what happens when I come upon a casualty. You know, this is what the environment was like, and it kind of opened their eyes, a lot, because like I'm not bringing all this crap with me when people are shooting at me. This is going to be like a staged thing, and so maybe early we'll be able to get these parameters. Later on, we'll start to be able to do more. But this is how the continuum of care is going to look. So they would have a better idea of how their product would be used, where it would be used, and so forth.
This is back to the feasibility study. We need to
Hmm.
energize people at SOMA to get a concept that of someone published research in ICU and Duke, grab that same research and do a feasibility study. Is that going to work at Fort Bragg in the middle of nowhere? And that is a pretty easy study that we can encourage the 68 whiskeys and the 18 deltas to do.
Like, it's not, it's us sitting in our different offices. That's super easy to do, easy to say. But you got to get the people, you got to get the time, you got to get the resources, and all of those things are in short supply right now. It's everybody wants somebody else to do it, and everybody wants somebody to fix their problem for them. Very rarely is somebody going to be the first to step forward and just do it, but that's what needs to get done.
It's a hard sell to get somebody who is on the ODA and they are deployed 9 months of the year anyway on these JSATs or missions, whatever we're doing, JRTC, and they're home. They're not going to want to take that time to work with the JSOM journal and create some of these studies. I totally understand why a lot of this research isn't happening.
Yeah. So I think kind of the answer, obviously I'm biased, but something like, Ragged Edge, where you have the retired guys, at least fairly recently retired, they still have the skills. Their bodies can still move. They're not completely shattered and broken. They can still do the stuff, but in a more controlled environment. And, we can study these things.
I think we need some sort of big picture discussion of people who are interested in pushing the science forward in special operations medicine. Because Ragged, I've been to the Ragged Edge team house and seen what you guys are doing there. It's fantastic. It's cutting edge, and some of the stuff we're doing here at Quorum, and then last month I was in Norway with some of the stuff that Dr. Jürgen Mehlau is doing with cold research. All of this is so important, but there needs to be a communication between all of these elements doing that research.
Yes.
How do we do that?
Yeah.
Is that the Prolonged Field Care Working Group?
Definitely it could be. It definitely could be. We're essentially all on the same chats anyway. How do you do that without almost a austere medical godfather influencing everybody's things? I think we all need to, communicate what we are doing, what we find, things like that, and that does happen. But I would like to see us be in a little bit more of a coordinated way versus I want to do this, so I just do it. Now, does that make any sense?
It does. I think we need a clearinghouse, and I think SMS and the Prolonged Field Care Working Group could step up and be this command and control or clearinghouse or communication for everyone who is interested in PFC to have collaboration, to have a joined effort here instead of the college doing what we do in Malta and then what the Norwegians doing. I'm in Poland next week. They're doing PFC stuff. What you guys are doing in Ragged Edge, what SMS is doing in Colorado Springs. We're not really talking to each other, are we?
Well, we're talking to each other informally, definitely. But it's more of like, hey, this is what I just did kind of stuff versus more collaboration, I guess, and leveraging what people are good at, what they already have the resources for, and working together to nail down a more specific area.
Perhaps an academic wing of the Prolonged Field Care Working Group.
Yeah. I guess how would that be? What would that look like?
Well, we'd have to get some of the people who are interested in pushing this forward to have a communication, have a discussion, have a language with the rest of everyone else throughout the world who is looking at this prolonged field care, and get everyone in the same room, virtual room, and start directing traffic or start having so we're not doing the same things, that we're like collaborating in a system where we're pushing this science forward in a clear and concise manner.
Yeah. I mean, that's obviously the dream, but all these things also cost money, right? So how do we? It's not enough to have a. I mean, it's easy to, I guess, easy to say and fairly easy to do as far as, hey, we have volunteers, and they help what they can, and we collaborate. We meet, once a quarter or something like that. Um, but when you're doing other people's stuff, say, Aebhric, I want you to, I don't know, study ultrasound techniques on the brand new learner. These 2, 3 different techniques. That's okay, if you happen to agree with all of them and you're willing to kind of put your company's or your school's name on the line for that. But if you're not, then you won't. Without some kind of funding where you can do this now separate from your own livelihood.
It's kind of like herding cats as well, trying to get everyone kind of on the same sheet of music. So good luck with that,
Hey,
Dennis.
thank you. I appreciate that.
On the Prolonged Field Care Working Group. We just created the academic wing of the PFC working group. So let me know how it goes.
I appreciate that. But it'd be awesome to work with, the JTS or a NATO entity or things like that, or all of them, all of the above. But I've found that doing it separately from the government is a lot more freeing, and you can move far faster, uh, and get better results when you're not tied to that. So I have to figure out some way to, I guess, look at grants or things like that, which is going to be another process.
Well, speaking of the PFC working group, can you give us a big picture on what precisely is that? So I know that you're part of the Specialized Medical Standards, the SMS, that you have, it's you and Paulos and some other people, Bill Vashis, so for the people who don't know precisely what the PFC working group does, we hear about the website and they hear the podcasts. So there's tens of thousands of people that access that every month. But what is behind the curtain, Dennis?
Unfortunately, sadly, there's not much behind the curtain. Like the podcasts, YouTube, all those things is essentially just me, and most of the website is just Paul. And we reach out for help from like the Sean Keenans and Jamie Reesbergs and the Bill Vashises and things like that. They all help and influence and advise. But as far as the work being done, it's mostly us two. Yeah, that's mostly it.
So money aside, let's say you have funding. Where would you like to see the PFC working group develop, or what's a 5-year plan for the working group?
5-year plan for the working group. Well, I think we've built a pretty good base right now. But how do we expand on that? I would love to be able to start working on kind of like how-to kind of educational type things, to actually how to get things done. It's one thing to talk about damage control resuscitation and the need for blood. It's another to do it. There's a lot of practical skills that are very basic that don't get practiced nearly as much as they need to. And I would like to, I think, having some how-to type stuff, and then I don't really even know how to tackle this, but maybe even to somehow bring a culture that we practice the small things, we master the basics, if you have somebody that has literally mastered the basics, I can take them far, much farther than a guy whose head is in the clouds who wants to talk about, using ultrasound to monitor cardiac output, but can't get an IV to save his life.
Are you taking volunteers to join the prolonged field care working group, or is there a plan in place for people who would want to help out if they could?
Yeah, absolutely. So, easiest thing, just email myself or Paul. It'd be Dennis or Paul at prolongedfieldcare.org. Express interest. This is kind of the test that so far nobody has really taken us up on, is that we'll ask you to do a thing, and it won't be a major thing like, record a video.
Make coffee?
Record a video, like do something. Make a cheat sheet, something. Do something for the mass, and you're in. It's really easy. And of all the people that have asked me about joining, and I, ask them to do something, and I give them a variety of options. I even offer, if they'd like advice or help, I would do it. But so far, nobody's really done any of it.
How can we light the fire under these people?
Once it comes down to work, that's where the desire actually comes in, and that's why Paul and I kind of agreed about having that kind of trial versus just accepting anybody, is because we need doers, not just people to email, and that's why we have such a streamlined group, a collective, is because there's not a lot of people there, and we're doing the work, and we love doing it, and decisions are super crisp. It's one text message between me and Paul, and then we move. But getting people to actually do the work, like any organization, that's the hardest thing. Any organization of volunteers, the hardest thing is getting people to actually do something. Everybody wants the name on their resume. They don't really want to be bothered that much.
Yeah, that's a valid point. It's a valid point. It's the same in academia, unfortunately.
Yeah, absolutely. How many people, like any research paper, of the people you see on the title, how many of those people actually wrote or edited, the majority of the work? How many of those people did the heavy lifting? Probably a couple.
The first one and the last one.
Yeah. Yep. Everybody else contributed.
So assuming that you get a vast amount of volunteers who are motivated, making coffee, doing creating content, what's missing in the current PFC curriculum? Where do you want to take PFC, and what needs to be developed?
I really think, just from the questions I get, I don't think people really know how to even practice. I see, training lanes that, they go for 30 minutes and they're like, all right, hey, we're going to fast forward 6 hours. This is what you get now. Okay, action, right? That's not how it goes. And you can't just fast forward to the exciting parts and get 96 hours of training in 6. Where actual prolonged field care really gets experienced is doing, 4, 6, 8, 12, 24 hours of actual medical care, and you're dealing with a healthy person. So he's got good vasculature, but he turned his body, which it turns out when you have living patients, sometimes they just do that, and the IV fell out because you didn't secure it well enough. That's where you find out that mastering those basics is where it pays off. And I think a lot of people don't really know how to do it. I don't think that they have lots of experience with patients to be able to present a patient, and that's the real difficult part about doing training is how do you present the learner a good model that they can now build off of and will actually learn.
That is a challenge, and people seldom have the patience or the drive to do a proper PFC scenario with no breaks, with no jumps in timings.
But I think when you do those jumps, when you do those gimmies, like you don't actually have to do an IV, just go ahead and tape it to the arm. You don't actually have to do the injection, just squirt it into the ground. All those little gimmies, they build a false model in the learner's mind about this is how it's actually going to be. And I think you're setting people up for failure because when they do the real thing, they've never seen it before.
A training scar.
And now you have a training scar. You know, when I went through the course, every patient that had some kind of chest injury, what can you imagine was his I guess chief complaint? Like he instantly had a tension pneumothorax that I had to decompress, and I'd been there 30 seconds, 45 seconds, and now he's already got a tension pneumothorax. Like that's a pretty rare patient to have.
It usually takes 40 minutes.
Oh yeah, and you build a training scar so that the medics now think if somebody has a chest injury, I must do a chest tube like now, which isn't true at all. And so even though I understand, hey, I need to see this guy do a procedure or these X number of procedures, just do a procedure lane. Like, show me how to do this, show me how to do that. And then keep the scenario kind of, I don't know, pristine as far as this is what it will look like when you have to put all these things together.
Yeah, we call them finger drills.
Yep.
And we do not like them at the college. My eye twitches when people say, "Oh yeah, sure, go ahead and tape it to the arm." So I understand that as a college, we have difficulty cannulating real people. So we make sure that there's an arm right next to that patient. So at least they have to cannulate it, or we have the sleeves so that you can cannulate.
Mm-hmm.
So there's at no time should you be doing any of these finger drills. And
even then, sometimes it's like it's not your day. Like that happens. You can have a perfectly healthy patient who has crappy veins. They're dehydrated or they're cold or whatever. When we're dealing with patients for real, like you can't get away from it. They still need the thing. Do you have other techniques about how do I still get the access so that I can do the procedure? Whether that be fluids, whether that be narcotics, whether that be something else. Just because it's hard doesn't mean that the patient still doesn't need it.
So your idea would be to develop a bit more of how to provide PFC training if you were going to develop more into.
I would start off with just basics, like how to do an IV. And I wouldn't leave it at, constricting band. I would escalate, using multiple constricting bands, using ACE-RAP, using, how to do an EJ, how to get a central line, like just how do you escalate? How do you do an IO? And now you have a more complete package of like, this is how you get access. Once I can get somebody access, the opportunities are much broader than if I have no access.
Knowing the basics well.
If I have as long as I have a patent airway, now I can do some kind of vent management. Now I can do some kind of respiratory management. Now I can do proning. Now I can do, there's so much. If I don't have a patent airway, he's going to die here shortly.
So, Dennis, now that you're retired, what's your 10-year plan?
So I'm actually not retired. I'm still in the reserves.
Oh, I thought you're still in 20th group. Ah, fair enough. Sorry.
No, I moved out of 20th group, and now I'm at first SFC, so I work part-time on the reserve side, but I plan on retiring shortly. I think my joints are telling me it's time to do something else. But my 10-year plan for that, I think at the moment, is just continue to push forward, continue making podcasts, continuing to make educational content, doing my best to influence the community in hopefully a positive way, so that we can just do our jobs better, care enough to do our jobs better.
Pave the way for other people to pick up the torch and run.
Yeah.
Dennis, my final question for you is this. What advice do you have for the new doctor, the new nurse, the new 18 Delta or 68 Whiskey who is just starting out on their career in austere medicine?
I mean, other than master the basics, that's the key, that's number one. Two, whenever you are stuck, the correct thing to do is assess your patient. People get stuck in algorithms all the time. The answer is always going to be assess your patient, find out what they need. But beyond that, if I plan on going into an austere environment, that's your plan. You have to be able to experience that in some way to really understand. A doctor, they're working in an ER and they're going to do some kind of medical vacation, some kind of humanitarian thing. Understand you won't have all that help. If you don't know how to do the basics, it won't get done. So being able to experience that environment, I guess in a assistant way or in some way, is going to be enormous benefit to the provider themselves and to their patients ultimately. Just because they understand the environment, it's going to be different. You're not going to be able to do all the things that you could at your normal job out in the woods. You just can't. And so that doesn't alleviate that the patient still needs those things. Well, what can you do with what you have where you are? And, I think also going with that assessments, because you don't have the resources, because you don't have the help, and you have lots of time, those assessments are that much more important, because you have to catch those pathologies early before they become catastrophic. You have to recognize the septic patient before they collapse, before they decompensate. You have to recognize, hey, this person is sick, and their body's reacting. They're stressed a lot more than they should. I'm going to start intervening early, hopefully before we were needing to put pressors and things like that on them.
So having the experience to see what's needed before it comes.
Yeah.
And that only happens with clinical experience.
It does. There's no way around it. There's no video, there's no book, there's no nothing it can all tell you this is what happens. I just did a podcast about dengue fever, and most of the warning signs that classify dengue are late. So we walked through, well, what does this guy look like early? I was like, oh, it looks like he's got a cold, right? So how do you differentiate the two?
Yeah, fever of unknown origin.
Oh, that's the advice I would give somebody.
I agree that get enough experience, see 10,000 patients. So that 10,001st patient that you see, you just know something's odd. You don't know why. You don't know how. You just look at them and you're like, this is not right. Dennis, it's great to have you back on the podcast. You are a pillar in the community. You have a torch in hand as you steadily tread onward into the darkness of what is austere medicine, and you're lighting the way for so many. Thank you.
Hey, I appreciate it.
This
has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.